Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision.
Welcome back, listener, to another episode of the Rural American Surgeon. I'm honored today to have a guest, Rebekah Wever, who just started practice with Mike Sarup in southeastern Ohio, and I've been looking forward to have you as a guest for some time. So thank you very much for joining us, Dr. Wever.
Absolutely, Randy. I'm really excited for this opportunity, and ideally, we can learn from each other and even help others out with this complex procedure.
Yeah, a young, freshly started person who's stamping themselves as a rural surgeon is always a person that I would love to talk to. And so let's start with an introduction, a little bit more of you, and tell us your background, specialty, training, and how the last 8 months has been for you.
Absolutely. So I grew up in this area as well, southeastern Ohio, Appalachia, Ohio, actually, and went to a really small high school here. Maybe 4 of us went to a college. Most of them were, 2-year colleges. And I stayed in Ohio, went down south a little bit, stayed in Ohio for undergrad biochemistry at Marietta College. Went over the west side of the state in Dayton for medical school, and I was lucky enough to get out to South Dakota, Sioux Falls for residency, mostly because I did know that I wanted to go back to southeastern Ohio and practice. I had been working with Dr. Michael Sarup as a long-term mentor. I started shadowing him in high school and went back as often as I could. He was a main reason why I fell in love with general surgery and helped me out a lot throughout my training. And now coming back here has been an honor to be able to work with him again. So,
yes.
Yeah.
A couple follow-up questions on that. Number one, how did you find him in high school?
He's actually very well known in our community. Kind of a figurehead here, still is, and will always be. But in high school, I knew I wanted to be in the medical field. Wasn't quite sure where I fit in, and since he's so well known, my family's like, well, just reach out to the office and see what they can do for you. So I did, and he graciously let me just shadow him around. So that's kind of how that happened.
So you didn't necessarily know you wanted to be a general surgeon at that point, and he probably significantly influenced that.
He very much did, yes,
yeah.
In every way. And he even helped me get into the other specialties. I was able to shadow our hospitalist here, oncology, the whole 9 yards, but definitely a main factor for why I just fell in love with general surgery.
Yeah. And so then when you went to South Dakota, when along this process did you commit to coming to Ohio, and what was that process like for you?
I actually knew before going into residency I wanted to work in a rural site. And ideally for me, it was coming back home. I love the community here, and again, wanted to work with Dr. Sarup, but I actually committed in my second year of residency. That really helped a lot with my training and getting ready to come back to this specific rural site. As you well know, every rural site's a little different in what they're capable of and what the needs are of the community. So I came back and actually rotated here during residency. I spent 2 months here out of my residency total, just learning kind of what I would need to be able to do and focus on during residency to be prepared to come back here.
Yeah, so wow, what a great experience. So they got you an Ohio license to be able to do that?
I did. I had a training license.
That's amazing that your program lets you do that.
It was. They were very lenient, and it was tremendously helpful.
And then you got to count your cases.
Yes.
It wasn't wasted time. Yeah. Oh, that's fantastic. So then when you came back, there was some question of, what can you bring to the community? Not just how can you do everything they're currently doing, but what else can you bring? And Dr. Sarup told me that one of those things he was looking forward to you bringing was Transversus Abdominis Release, which we're planning on doing for our How I Do It today. Let's get to that in a second. Was there anything else like that, though, that they said, hey, do you know how to do this or that? And you could bring it to our community?
Yeah. So actually, one of the main other procedures that I knew I would really want to be able to do was ERCP. And I worked with our advanced GI endoscopists throughout residency as much as I could, but they also had their own expectations and didn't hand over the reins very often. It's just how they were. And I actually got a lot of my experience when I came back here for those 2 months doing those procedures. And I'm still working with them, but getting more to the point of doing them on my own here as well.
Good. So your group that you joined, how many surgeons are there?
There are 3 others.
Okay. And they were independent for a long time. I think Dr. Syrup told me they recently became, is it hospital employed or contracted, or how are they doing it?
Yeah, we are hospital employed now with Ohio Health. And that actually, the transition occurred when I signed on.
So that would have been like 3-4 years ago?
Signed on like when I actually came
when you
here.
Started.
Yeah.
Well, was it part of that? Like, now tell me, go back to second year. What did they give you anything like for that commitment? For example, any sign-on bonuses or stipends or income guarantee, anything like that?
Yeah, so they did help out with a stipend.
When you say they, it was the hospital or was Syrup's group?
It was the hospital.
So you were committed to the hospital, just having a relationship and knowing Dr. Syrup.
Correct. Yes.
And you could have came in and basically competed with your mentor, but you did the right thing and you're all banding together as surgeons. One question we ask every guest is, why is rural surgery special to you? I think that there's some obvious, things that we could assume, but in your own words, what's so special about what you're able to do right now?
Yeah. The main thing for me, it really is being able to provide care to the community. And, we have a lot of farmers, a lot of people really attached to staying local for their care. And, my goal was to bring back as many higher complexity procedures that I could so that they wouldn't have to be transferred out. And our patients really appreciate that. They all like to stay local. They want to have their family here with them and not travel so much. So that's been kind of the main thing for me, and just being able to help my patients in that way.
Yeah, for farmers, that's such a career that's so tied to the dirt, to the ground, to that specific spot. Like when you plant crops, like it's not going to be anywhere else. Now we have a lot of remote work and freedom of travel more than any time ever. You could have maybe like a shop owner, who has a physical location, but farming is special like that. And so I moved back to the family farm that I grew up on. And again, there's no other plot of ground that, has been plowed for that amount of time by my family. It's really cool and special. And it's funny, I'm just saying all that because you brought up a farmer as the quintessential rural patient that you're taking care of.
Absolutely.
Of course, they want to stay local. So great. Well, why don't we roll into the how I do it? We're going to talk about ventral hernia repair, specifically with a transversus abdominis release. And the reason I wanted to talk about this is I was talking to Dr. Syrup about you coming, and he said, we're really interested in adding that to our practice and looking to you to help do it. Now, my understanding is at this point, you haven't done any in your first 8 months, right? Which makes sense. Right. I maybe do one a year. It's for that person. It's got to be the appropriately selected patient. It's got to be somebody that's not too sick to have an operation in the rural hospital. And it's got to be a ventral hernia that's big enough that justifies a TAR. But that being said, we're going to dig from your residency experience. I can chime in a little bit as well. But the ventral hernia repair that's going to get a TAR, do you always do that with a Reeves Stopa retrorectus mesh?
Yes. So it's really just an extension of that modified Reeves Stopa from the original explanation of that procedure. It would be, I use a phasix mesh, different configurations to use depending again on how much you do have to mobilize depending on their hernia that they have.
Mm-hmm. So you're putting a phasix in the retrorectus space. I would say a lot of people use a a polypropylene plain mesh because it's not being exposed. So tell me about the choice to use Phasix.
Yeah, so my attending in residency had a lot of good success with Phasix. And I like that, you have the macroporous, microporous, and this one's a knitted monofilament. And so it's pretty well incorporated. And it's also shown to not break down in the setting of a bacterial field. So not that, we want any of our patients to get an infection, but that's just an added, let's say, barrier to that dreaded complication. So,
yeah, antibiotics until the cows come home, and a Phasix should not have to be excised, right? That's
yeah, pretty much. And it gets really well incorporated. So it's kind of a win-win.
Yeah, great. So to be a little more structured with my introduction into your talk about TAR, why don't we first say who's the patient that's getting it? And in order to sort of complete that spectrum of hernia, okay, who don't you do in the location where you're at? And then what do you do with the other hernias that aren't candidates for TAR? You see, so like the whole spectrum of basically ventral hernia. So maybe starting with size, or what other criteria you use to decide those things?
Yeah, like you had previously alluded to, patient selection is key. This is a pretty obviously big repair, and you don't want to do this on someone who isn't optimized. A lot of my patients, unfortunately, they're smoking. They're smoking packs upon packs a day. So that's first and foremost. I will tell them they have to stop smoking. Because again, very high likelihood that they'll have a recurrence or some type of wound complication and maybe a mesh infection if they were to continue smoking. The other thing is, losing weight. I don't believe that my population has a significant issue with this, but it is more pronounced in the patients that come in with these larger ventral hernias. So ideally, they always say BMI of 35, but I've noticed with the few consultations that I've had, it's extremely difficult for them to obtain. We keep working on it, and if there's no, higher risk patients that come in where they're starting to notice some incarceration symptoms or this, that, or the other, we keep working on getting that weight down to an ideal BMI of 35. I'd be comfortable maybe going up to 40 if they've plateaued out, and other risk factors like smoking, of course, making sure their diabetes are optimally managed as well. We have a lot of that here as well, unfortunately. So the patients who I wouldn't take to the operating room are those patients who, they have one or the other they can't optimize, and then another factor, such as if they've had a loss of domain. Those patients really require a little bit more preoperative optimization, in addition to what I have previously mentioned in terms of maybe they're a Botox candidate or they need progressive pneumoperitoneum, which we just don't do here.
So is there a specific size that you have in mind?
Oh, sure. So, I would say not any specific size necessarily. Now, we all know the typical advancements with these type of repairs. You can get up to, a 20 centimeter hernia with optimal release of that transversus abdominis. But those they're probably also better treated by transferring to a larger center who the only thing that surgeon does is hernias. So I would say probably about 15 centimeters would be my maximum.
How comfortable were you coming out of residency? What were you doing independently? I guess expound on that a little bit.
Yeah, wow. So in regards to Fix the 5, if I remember correctly, that was more so, our academic residency programs who, you would maybe not operate until your 4th or 5th year, and then you're not comfortable operating and would need to go into a fellowship. Well, our program, we got our interns into the operating room pretty quickly on. I remember starting on our trauma and acute care service, and I was in the operating room doing a gallbladder within that first month. Great senior residents, great attendings. And so then you just build on that, and getting your residents into the operating room sooner really just excels the process of getting them ready for practice. And that was their whole goal. So it was a great model. But I did quite a number of procedures independently. I was even a third year for a lot of the cases, the more standard ones, your breasts, your appies, your gallbladders, and of course not the very complex gallbladders. But by the time I was into fifth year, speaking back to Dr. Matt Sorrell, he would let me go in and start these open retrorectus cases, and he'd come in later, which gave you a huge amount of confidence and feeling like you were ready to do these cases, and also helped you learn kind of what you weren't sure on, right? That back in second year of residency, we were able to go to a rural site, and those attendings would also just let you go, and it'd be based on their confidence level in you, of course. But so our attendings, let me think back to specific cases. We did a lot of robotics, and then trying to focus on hernias. I'd be doing most of those cases on my own, starting in middle of fourth year or so, the more standard robotic hernia cases, or the attending would just be there retracting and let you do your own thing, even starting third year.
So by the time you're a chief and you're doing a retrorectus with a TAR, did you incise laterally before the attending was in the room?
No. So he would be doing one side, I'd be doing the other side.
But you would get the hernia sac all dissected free and get the retrorectus space completely freed up?
So
before he came in?
The retrorectus space, he'd be in there by that time. I definitely took my time freeing up adhesions and taking down the hernia sac. A lot of these patients had a significant amount of intra-abdominal adhesions. And so just that he gave me that time to do that was...
Do you enter the abdomen on all these cases?
Yes.
Okay. So in terms of maintaining the sac and pushing it down and then going to the side and just staying outside of the peritoneum, you've never done that before? Or
what do you mean? Sorry.
Like I'm saying, if you can keep the sac intact, like for me, if you're doing a TAR, or if you're doing a Reeve Stopa, you don't have to free any abdominal adhesions because you're just trying to get the sac back in, get the posterior sheath back together, and put your mesh there. But did you guys do a full interlysis for all of them?
Yeah, at least all the ones that I was involved in, and mostly because it does help decrease the tension on your flap to be able to pull that together. And it could have potentially helped us do less dissection and maybe even avoided a TAR in some of those cases where we just did a Reeve Stopa.
Yeah, that makes sense. I mean, you have to obviously see where you're throwing your stitches to get your posterior sheath closed, so you have to do some.
Yes.
Yes. But okay, fair enough. And then when you came out of residency, so basically you were when you had to do some credentialing process, I assume. And did they require some sort of proctorship, like a certain number of cases for you to be doing with somebody else watching you when you first started for your hospital privileges?
There weren't any specific requirements that I was aware of. I would more so actually just scrub in with my colleagues as much as I could. Not that they were coming into any of my cases even. Now, with certain ones that, like I mentioned before, the ERCP, I hadn't done as many as I would have liked in residency. And so we're doing that type of proctorship throughout those cases.
Is it structured like you're turning in the cases as you do them? And
I'm keeping a log of the cases that I've done. And those have mostly been with Dr. Sarah.
Did somebody ask you to do that, like the credentialing committee?
No, this was kind of just a combined decision between Dr. Serap and myself. Because again, I you want to be able to know your limitations when you come out of residency. And if I had felt, unsure of any particular case, I would just ask them to come in with me to help out. And
So like the first time what was the first case that you did out of residency?
So my first case out of residency, I started on call that weekend, and I had an acute abdomen that came in. They called me right away, and I was like, well, there's a number of things that could be happening based on your symptoms and your exam. We just need to get you to the operating room. You're septic. I don't need a CT scan to tell me what to do. And so we went into the operating room and X-lapped him, found a perforated prepyloric gastric ulcer. So that was quite the case. Newly diagnosed cirrhotic with ascites as well. And so.
Oh my.
That was great.
So did you call somebody to come help you with that?
I did. So that being the first case, going in, not knowing what was going to happen. And I had one tech. I was like, I want to get this guy off the table as quickly as possible. Not only have, second set of opinions and everything. I did call in Dr. Serap.
And you went with no CT?
Correct.
Ha! And but it wasn't mandatory that somebody was with you?
No.
You just called. And did you know for your first, how long, do you take like a week of call at a time, or how do you do call?
We do call 1 in 4. So it's been great. I'm on call with my operating day, which is on Monday now. And then that being said, when I'm on call on the weekend, which is we take a Friday through Sunday, through Monday morning, technically, I'll just have Friday morning to Tuesday morning when it's my weekend.
And that's every 4th weekend. That's a sweet setup.
It is.
So did you already talked to Dr. Serap ahead of time for your first day on call and like say, hey, if I need you?
Oh, absolutely.
You knew he was in town.
Yes. I know who's in town every weekend with me.
Yeah, that's fair.
Absolutely.
Good. I'm just kind of thinking in my own experience as you're talking. That's why I'm like in my own head over here. So don't worry about it. You have such a great setup, and it sounds like such a great group that they've just really allowed you to come out swinging and knock out a case like that. So that patient, what kind of operation did you give them? I'm just curious.
Yeah, modified gram patch repair. So luckily enough, and it was interesting, I believe that he had been perforated for a while, but his ascites had actually created a more favorable environment. Absolutely. And so, he had really good tissue around this ulcer. So I reapproximated that and then brought up a patch of momentum.
Yeah. So what did you use to close the hole?
So I actually just used some ethibonds.
Did you debride the edges a little bit?
Yeah, he didn't need much though. Again, that tissue looked pretty well.
And so like how many stitches approximately did it take?
Shoot, I'm trying to think back. I think I put in about 4.
And you did it transverse closure?
Yes.
And it was just a through and through stitch, or was it some sort of Limbert stitch?
No, it was through and through. Yep. Get all the layers.
And gram patch has been described different ways, and I've seen it different ways. But one way to do it is to leave the long tails on, and then bring your pedicled tongue of omentum up and lay it on top, and then stitch down with like that knot staying there. The other way would be like if you just did some bites on either side and stitch your tongue up. How did you do the tongue of omentum?
Yeah. So after primary repair of that, you get a little further out on either side. You take your stitch through one of those sides and then through the omentum actually, and then on the other side as well.
Yeah, and I've also seen it where we go through the omentum or not through the omentum. But that's exactly how I'd like to do it. Now, did you do that with a vicryl or with a permanent stitch as well?
So that one was with the vicryl.
3-0?
Yes, it was.
Cool. Man, great case. If you had it to do over again, you'd do it open?
Yes, I would.
No circumstances you'd stick a scope in?
No, not in that particular patient. Again, he was septic and undifferentiated. I was pretty confident it was a perforated gastric ulcer, just again, his symptoms and his exam and history. But again, undifferentiated, you just want to get in there, get the patient off the table as quickly as possible.
Wow. Yeah. I would say they fixed the 5 in South Dakota if you're doing that day one and without a CT and then just nailing it, knocking it out of the park like that. That's awesome. Have you seen this guy back?
Yeah, he's doing great.
Still alive.
Absolutely.
Amazing.
This was actually a pretty eye-opening experience for him. And a lot of our patients here don't keep up with their primary care physician. So I was his primary care physician for a while, trying to get him better optimized and everything. But that was
so he stopped really smoking and drinking, and
he
got baptized, and now he's
much.
good to go. All right, that's awesome. Well, that's just such a cool story, and we need to get back to TAR. So say it's this patient, and he comes back with this huge ventral hernia later. Let me go to the other extreme first and say you got a 1 centimeter umbilical hernia. You're not doing a TAR for that.
No.
Right. So at what size do you place mesh? At what size do you do the retrorectus? And then how do you decide who needs the TAR?
Okay. First things first. So with when to place a mesh, it's a lot of patient factors too that you want to think about, but in terms of specific hernia size, 1 to 2 centimeters, the recommendation against is 2, but you have a lot of patient factors to weigh in on that. And then when to do the retrorectus, those are usually going to be those patients that come in. A lot of them that I've seen, incisional hernias, they're, upwards greater than 5 centimeters. If you can pull them back, primarily, great, and place a mesh. But you always have to just counsel the patient on, all the possibilities. So that's kind of how I go about that. It's not that, every hernia this size is going to get repair with a mesh or get a retrorectus. So I just say, ideally we do this, but if I have to, I can have these other options on the table.
Do you have a robot down there?
We do not. We are currently working on it. And last we discussed it with Ohio Health, it was on the budget.
Okay.
Well,
so
we'll get there.
Do you think that you're doing your patients a disservice by not having a robot specifically for ventral hernia?
Not necessarily. So now, would it be nicer? Potentially. However, in terms of the repair, no. What I do is for ventral hernia repairs, they're just standard. I do an open primary closure. So, let's say umbilical hernia. I'll dissect that out, place my sutures, and then go in laparoscopically and place a larger mesh. So I believe the repair is just as good as robotic.
Yeah. What kind of mesh are you using there?
So that would be also a Phasix mesh. Okay.
Do you use any permanent mesh for ventral hernias ever?
No. And that's, again, our supplies here. We do the ST Echo for those ventral hernias.
Phasix ST Echo,
yes, Echo
is what you're using.
Yep.
And that's like either a circle or an oval shaped?
Yeah, we have the circle shapes here. We have 2 different sizes. So.
Okay, like an 11 and a 15, or do you have bigger than that?
Oh, not any bigger than that, no.
Okay, sweet. So then we get to a point where on this particular patient, you're saying that's not a good option for you because I think your hernia is big enough and we are going to want to put a retrorectus and we're going to have the extra reach. Now, how much extra reach do you think you really get with the TAR on each side?
On each side, so let's see, probably a good 10 centimeters maybe, if you're really releasing the entirety of that transversus abdominis.
Okay. That's a pretty good, reach. Then you're saying you could bridge a 20 centimeter defect by a bilateral TAR.
Yeah, theoretically. So that's really...
I agree, theoretically.
Yeah. So that's what, all the literature says. By no means have I had to do that extensive of a dissection. But again, all the readings and the articles, they're like, you can get up to 10 centimeters each
What
side.
do you think in residency was the biggest hernia you actually fixed using this technique?
Ooh.
Just by memory, and that was a time of your life where you're trying to black out. So I get it.
Very true. But had to think back, probably 10 centimeters, at least on the ones that I've done.
And there's a transverse defect, and then maybe it's 15 top to bottom or something. Yeah. So say you have a patient like that. All right. I think we've waxed eloquently, and we probably need to jump ahead. Our discerning listener knows how to make an incision, get down, dissect the sac free. Maybe you freed all the intra-abdominal adhesions. You've excised a portion of your sac. You've done a retrorectus dissection bilaterally. Okay. Everybody knows how to do that. Now, how do you do the TAR?
Sure. So the important thing is you completely dissect out your retrorectus space. You have the arcuate line, and that's going to really help identify your incision for the TAR. It's going to be, again, 1 centimeter medial to your perforators. But if you see that arcuate line, you can get your tonsil, Kelly, whatever you want to use through there and dissect that plane out before you cut, which is a huge important step to make sure that you're getting into the space the first time.
Okay.
Again, through residency, you kind of learn your little key steps and whatnot, of course, but that's kind of how I would start doing that. If you want to look at it, more cranially, you have those transversus abdominis fibers that you can see coming through that area as well. So.
Okay. So you start caudally, however.
So yeah, with that arcuate line and developing that.
And you're talking about the arcuate line, not the semilunar line.
Correct. Yeah.
And so you jump on. So you got cokers on your fascia, and
Yep.
you're pulling it towards you.
Right.
And then you're inferior, and you see your arcuate line, and you go below the arcuate line. And where exactly do you put your tonsil?
So you're going to develop that plane, and you want to be 1 centimeter medial to those perforators.
Okay. And then do you have any tips or tricks on how to identify the perforators?
It's again just making sure that your retrorectus dissection is complete, because those are your lateral point of your dissection. And so taking it slow, doing blunt dissection, cautery when you need to. And again, when you're getting out to that aspect, just be cognizant that they're coming up pretty much.
Okay. And then as you are approaching how do you do the rest of, like, going from, you go all the way from the bottom to the top, generally like a zipper then?
Technically. Now, a lot of the times it's really just what the patient planes are giving you, right? If they're more difficult caudally, then you go somewhere else. And then the rest of it will show itself to you as long as you do what's easy first.
And so then the first thing you see after you incise the fascia, you see the transversus muscle fibers.
So yeah, you should be able to see those, and those should be pushed, again, upward.
Like upward, you mean up and lateral, right? Away from you?
Like up away from your fascia. That's fascia.
Okay. And then you're dividing that muscle fiber between a clamp with a little Parkinsonian trimmer. Any other specific little tips like that?
And so taking it slow, again with your instrument, Kelly, or whatever you want to use to develop that, playing with those muscle fibers.
Okay.
Going slowly with that, again, just decreasing your bleeding and everything.
Yeah. So you work that all the way from top to bottoms, and then your mesh is going to go out into this plane, underneath the cut transversalis muscle. How far out are you placing your mesh? What size of mesh are you going to be using? So
the mesh, for me, ideally will just coat the entirety of my dissection. However far out we need to mobilize to get that tension-free closure of the posterior and anterior rectus sheath. So, largest one. I mean, sometimes you have to use 2 meshes actually, and you can do if the standard square, because again, you're going to have more of an elliptical rectal space. You can, just angle the mesh in a diamond shape if you're looking at the patient straight on, or you
cut
can
the corners off.
Yeah, or you can use kind of I've heard it explained as like a baseball diamond, where you place the mesh in a diamond shape, and then you use another square or a rectangle, whatever fits that more cranial aspect of your dissection.
Okay. Very good. So how do you secure the mesh then?
We had, I believe it was PDS, and you would do a few lateral, but then you would also re-secure it to your posterior rectus closure along the midline. So.
Okay. And I didn't ask this, but you closed your fascia with what?
So that was with 2O PDS.
2O PDS. Okay. So you're going to throw a few stitches to secure the mesh, just kind of around.
Yeah,
and
laterally. You want to, of course, make sure that the mesh is laying flat, and then down the midline of your posterior rectus closure.
All right. And then you're always getting the anterior rectus closed over the top of this?
I've not had any issues with that. Again, however, I've not had any issues with closing the posterior rectus sheath either. So.
Yeah. So then you're closing that with the 2O PDS as well?
Yeah, kind of depends on the tissue. You can use a 2O or an O.
And you like these O single strand, or?
I do. I use the O single strand.
And that's running?
Yep.
Okay. You throw a stitch at each end and then tie it in the middle, or?
Yep.
Okay. And you're leaving drains for this?
I do. I leave a drain in that rectal rectus space above the mesh, and then again subcuticular. Okay,
so your first one comes out to one side, you know where it is. The other one comes out to the other side, so you know where it is.
Always, the rectal rectus space coming out on the right because R&R, and then
R&R.
Yeah, it's.
And you just kind of coil it over the top, or.
Yeah, so there's going to be 2 drains in each space, and one is going to go so along the right gutter, and the one's going to be on the left.
Okay, so 4 total drains, or 3
Depending
total
again,
drains?
If the subcutaneous space is amenable to 1 drain, that's fine. But I would put 2 in that rectal rectus space.
Okay. Those are 19 French round JPs, or what do you use?
Yeah, those are JP drains.
Okay. I'd like to jump ahead to usually our last segment, which is resources for the busy rural surgeon, because I want to ask, is there any resource like your first TAR that you go to do? Are you just going to list it and you're just going to go? Or is there anywhere you're going to go to like freshen up, and like a video resource or anything of that nature that you could share with us?
Yeah, I mean, nothing necessarily in particular. There is a book, however, that I would recommend, and it's going to be the let me think here. Hernia surgery. I think it's current principles. Shoot, I'm blanking on the Nowitzki. That's what it was. That book I would, again, just brush up on, and, reach out to my attending from residency, just say, hey, have you changed anything? What have you found to be more beneficial, again, from when I was training, because everything changes. It's a constant change nowadays. And so reach out to him, just make sure there's been nothing new that he's found that worked for him, and go from there. I would definitely ask one of my partners to be in on these cases as well. We mentioned that aspect of my career earlier. So,
all right, wonderful. Well, let's move on to the next segment of the show then, which is the financial tips. So, did you have student debt at any point, or do you still?
Yeah, I do, but a lot of it, my family did help tremendously, and so it's a balance of interest rates on that versus the home versus long term. What's going to be the best to pay off sooner? Obviously, you want to focus on retirement, so it's all a balance.
You're not planning on public student loan forgiveness program, or are you? No. Okay.
No, I don't necessarily qualify.
Yeah, that's fair. And then tell me a little bit more about signing your contract early. So you were a second year resident?
Yeah, so this was before Ohio Health, and so I got a new contract with Ohio Health.
Okay, but they assumed all of the terms of the initial contract?
Well, we had a new contract actually with Ohio Health.
So by the hospital, so the hospital was independent before that?
Yes, as far as I understand.
Okay, and then by the hospital, but you did sign a contract with that original hospital. What was it called?
It was more so just an agreement to come and practice there after residency. I didn't have any major stipulations that I'm aware of. I mean, maybe they said something about working for so number of years, but a new contract with Ohio Health was purely their contract. They like to do things their own way.
Okay. Well, I'm saying with that initial contract, was it like you just had to come here and work generally in this area? You could work for yourself and bill on your own, or was it like, no, you're working for the hospital, we're billing for you, you're on call a certain amount of time, like?
No, and it was more so that I would come and join this independent group here, but work through their hospital.
Okay. All right. Do you mind sharing any details of that? You don't have to.
There weren't really many, I guess. It was still pretty early in the stages, and we were going to revamp it a little bit more, but with the group becoming hospital employed, there was no reason.
Yeah. So, but what they were willing to give you was a monthly stipend of a certain amount of money.
Yes.
For that commitment to come work there.
Yeah, pretty much.
Do you have something for that classic rural surgery story? I mean, you kind of already did it with your perfed ulcer. Did you have anything else that you wanted to tell a story about?
So the only other one that really sticks out to me was an elderly gentleman, frail, malnourished. He had just had a cabbage 3 weeks ago and comes in to our emergency room, and I get called, midnight, classic, but they tell me, oh yeah, it looks like a concerning hernia. And I go in and I evaluate him, and unfortunately he has gangrene of the skin overlying this right inguinal hernia. And so it's obviously been out for quite some time, and he let it go. And then there was an underlying abscess. So we take him in the middle of the night. Obviously, don't want to sit on that. I did this through a groin incision, try to keep the contamination within the groin outside of the abdominal cavity. We got pretty lucky. We didn't even have to release much of the pelvic floor to be able to resect we had to resect the terminal ileum and first part of the cecum. We were able to do that anastomosis through that inguinal incision.
Okay.
And left him open, kept him in the hospital for a few days. And once it appeared that infection had cleared up and the dead tissue demarcated itself a bit better, I took him back to the operating room, debrided that extra dead tissue, enclosed him, left a drain and everything.
Mm-hmm.
But yeah, I was pretty worried about him, mostly with his recent cabbage and his underlying medical conditions that
he's fixed.
Yeah,
with the cabbage,
Yeah.
Good to go. All right, so that was an indirect hernia or direct?
Yes.
Okay.
Indirect.
And it was obviously right.
Yep.
Because you had to do the ileum. And the perforation, was it in the ileum or in the cecum?
That was in the cecum.
Man, so you had stool in your wound with the abscess that had been festering and stuff?
Yep, all of it.
Wow. So when you, did you resect the testicle?
Yes. It had pretty much depleted and strangulated the testicle blood supply. So it wasn't really viable either.
So you did an orchiectomy. Your hole that you're looking at was like, 3 centimeters or so? Like something that you could get an anastomosis back through?
Exactly, yeah.
Okay.
Yep, about 3 centimeters.
And when you did your anastomosis, it was like a side-to-side
Side-to-side
stapled anastomosis?
Yeah, stapled.
Okay. And then you're just able to kind of milk it back through, no problems. Did you do any overstitching? Did you do a crotch stitch or anything like that? Oversew the staple lines?
Yeah, we did the typical, side-to-side staple anastomosis. You do a cross stitch. I didn't oversew the staple line. I've never done that with any of my stapled anastomoses.
Okay. Yeah, great. And you kept saying we, so I assume you called a partner in for that one. How far into practice were you? Like how many months at that point?
Shoot. That was probably 4 months in, if I had to guess. Yeah.
Yeah, and I just have one last question for you. So in your residency, how many cases did you do?
How many cases total?
Yeah.
I was at 1,500 total major cases.
Well, thank you so much, Dr. Wever, for joining us on this episode of the Rural American Surgeon. It's really been a pleasure to have you.
It's been a pleasure. Thank you, Randy.
And for the listener, thank you for joining us today. We really appreciate you being here. Thank you for giving us those ratings and reviews. That helps us on our overall algorithm for Spotify, Apple Podcasts. Please don't forget to tell all your friends about it. Share some of the posts. That really helps us get the message out to the affected audience, which is really a small but niche group of people, which is the rural surgeon. We just appreciate you having us in your earbuds today, and we will see you on the next episode of the Rural American Surgeon. Thank you.